What's up, everyone?
Hey.
Yeah, we we put Bill over there in the corner today, and he is not driving well. Olivia, and he's using stupid sound effects. And Olivia's doing her best to keep him in check over there. So
She's got her
sorry.
hands
You don't
full.
call retarded people retard.
So he's like pushing every single button on there.
He is. He actually said that was my intro. So
Oh, okay.
Yeah, so when you introduce her, we'll give her intro.
Yeah,
music.
yeah. So welcome to my wife, Dr. Carrie Hardy, also Brazilian Jiu-Jitsu black belt. Just had her birthday, and I won't say how old. So
I don't give a shit. I'm 58.
All right.
It's a number. I don't care.
Awesome. And we brought her on because we had a ton of testosterone questions that, you know, I kind of half-assed, honestly. And since you're the resident expert here, we thought we'd bring you on. Especially, this will likely be the last episode we'll do in this studio because Bill and Olivia were very sad about it. They're relocating to Arizona.
Spoiler alert.
I know.
Spoiler
Well,
alert.
I'm going to put it out there.
Well, the podcast's still ongoing.
Yeah. We're going to be doing it in a different format, kind of, what would you call that? Like Zoom based or something, Bill?
I mean, I'll be on the toilet.
Yeah.
You'll be in your bathtub.
Mhm.
Yeah.
And then we're just going to see where it goes.
Yeah.
Bubbles galore.
Yeah.
So if there's a little, kind of some one-off episodes or some, and this month would be a little spotty perhaps. So just bear with us and we'll get back on track though.
I might do one from the car on the drive down.
Oh, that'd be amazing. Because I know you were saying at dinner last night that you were planning on stopping at a ton of jiu-jitsu academies that Olivia had zero idea was your plan, which was
Zero idea.
hilarious.
That was
I don't know. The surprise on her face looked pretty real.
He's like, yeah, we're going to stop by here. She's like, we? what are we doing?
Guess I'll Uber.
So anyway, we're going to miss them up here.
Very much so.
So it's kind of sad for us, but I'm happy for them.
Yeah.
So we'll get to it because we have a lot of questions today for you, Carrie. And
Okey dokey.
yeah, and
What is
go ahead.
today about, my friend? What's the main topic?
I just talked about that.
I know, but do it again.
Oh my gosh, dude.
It's the testosterone episode.
Yeah, so we're
Masterclass.
It is the dude juice.
the dude juice.
Okay. That's
Yeah.
one way to put it.
I like it. Well, women use it too.
We don't normally juice though. We get pellets or maybe a little cream.
Yeah.
We're getting there.
I have a couple that'll inject.
Okay.
Yeah.
Nice.
Don't spoil it.
Okay. So we've been compiling these questions for several months now, right?
Yeah, and we didn't choose every single one, but we did choose some of like the main ones that we got we got the same question a few different times,
Mhm.
Okie dokie.
and we're gonna just address some of those, the very common questions. Otherwise, this would literally be a 3 to 4 hour podcast.
Right.
So I did dwindle it down a bit and word a couple that kind of have a couple different people's questions.
You dwindled it or did you whittle it?
Both?
Okay.
He dwiddled.
That's what I was called in high school.
No, that was diddling.
Oh, that was middle school. Watch your mouth.
Okay. Okay.
Well, speaking of that, let's.
Excited to get demonetized. That's great.
Yeah. we're racing to cancellation.
Yeah. So with that, I'll just kick it off. Well, before that, for people that do not know, we do have a testosterone episode where we did basically this before, and I think it's episode 10, which was a long time ago, about 2 years, I would say. And we deep dove into that. It's probably our most listened to audio podcast. On video, though, it doesn't have that many views. So I do recommend jumping back to that if you're interested, because we'll probably touch on stuff in that we don't today.
I'll just add that I know from living with Carrie, I know how many more conferences she's been to keep absolutely up to date. How many more since 2 years have you done for hormones, especially? You think
Typically 1 a quarter.
1 a quarter, so
Yeah.
probably 7 or 8 since the last one. So she's really up to date on the stuff. So I'm anxious to hear what she has to say. Let's go.
Yeah, absolutely. So episode 10, if you guys want, there's more there. And we're actually on the YouTube channel, we're going to make a playlist that has every episode that references TRT or testosterone or hormones in general, because we have a really good female podcast that is not just like for people working out or grappling, but just in general women's hormones. So we're going to have a playlist on there and you guys can really deep dive. With that, let's kick it off with a non-TRT question.
Excellent.
I love it.
Recommended multivitamin, if any.
So we have to be careful. So typically I recommend mostly brand names, basically either Thorne or Pure Encapsulations, because those two aren't having you take like 1,000 capsules a day just to get the nutrients that you need. I will say that there have been unscrupulous individuals that are taking the labels from those name brands and putting them on substandard products. So be very careful about ordering things on these big wholesale warehouses, not to dime anybody out, but typically it's coming from Amazon. And when you report that to Amazon, they are very good about taking care of that. But the ones that I like best are Pure Encapsulations 1, O period, N period, E period, and the periods are in between each letter. Multivitamin, that's because you only have to take 1 capsule per day. And then Thorne's, basic nutrients 2 per day, and that's because you only need to take 2 capsules per day. So if you can, try to go directly to the manufacturer's website, either Thorne or Pure Encapsulations, and get it from there. Or if you're getting it from Amazon, just be careful about third-party sellers.
Well, that's really good info. Well, and do you know how they figured it out? Were people complaining about something?
Yeah, like they weren't getting some of the same effects. Like we saw it a couple of years ago with some of the mushroom blends. And I think it's happened most recently to Host Defense, where somehow someone...
Oh, Stamatis Company?
Mm-hmm.
Oh, wow.
Yeah, where because, they're also sold on those other third-party sites. Yeah. And I can't remember the exact details behind it, but I think somebody was like, I'm not getting the same benefits that I normally feel from this mushroom blend. And they reported it and then found out that was a third party relabeled it to look like his brand.
Oh, wow. That's terrible. And who knows what was in it, right?
Exactly.
Okay. Wow. And before we get started on this, we talked, that question was a very good one. Does everyone, first of all, my questions are, does everyone need to take one? And second of all, we hear, some of our colleagues will say that you get everything you need out of food.
Yeah. And so I think unless you are a avid gardener and have your own fruits and vegetables at your own place where you know that they're being picked fresh and you know about the soil and it's a nutrient dense soil, then I would say you most likely don't need a multivitamin. But for most of us where we're getting our groceries from the grocery store to include our produce, unless you're frequenting the farmers markets, then you should probably get a multivitamin, because a lot of the larger farms, they are not able to replete their soils appropriately. And so I don't think they're as nutrient dense. Plus they are picked earlier to get to the store, which decreases the nutrient quality out of those fruits and vegetables.
And I've heard as soon as it's out of the ground,
it starts to lose.
You start to lose the potency and the availability of those vitamins and minerals, right?
Exactly. So I would politely disagree with our colleagues that say we don't need it, that you're getting everything you need from food, because clearly you're not.
Not anymore.
Not
like
anymore.
You said, the over farming of these things, and we're losing topsoil and all kinds of things just to this over farming, monocrop agriculture, right?
Exactly.
Okay. So that's excellent. Now, is there, some of these things are a one size fits all. Are they pretty safe to take, no matter who you are?
In general they are. And there's some kid version ones, right, where the quantities are a little bit lower, because say what you will about the Food and Drug Administration, but their USDA guidelines as far as nutrient intake, at least those basic nutrients, is good. Some things we really don't want to overdo with multivitamins, and I think we can go too far without appropriate testing. Things like selenium and iodine.
Vitamin A, maybe too.
Vitamin A because it's fat soluble.
Right.
Vitamin E, fat soluble also. But, you know, a lot of these guidelines have shifted over the years, much like lab values, right, to try to keep more of the population within the norm. So arguments about what's actually needed for health may be a little bit different than what we think they are, but at least following those basic guidelines by the USDA is at least a good place to start.
Isn't that the recommended daily allowance as far as, is that just basically what's able to keep you alive, or is that optimal?
No, I think that's just what's able to keep you alive.
Right.
I doubt it's optimal.
Right.
Because if we talk about something, and that's a whole nother podcast all by itself, and I think you even did one on vitamin D. But there's some people that, you know, they're saying, oh, well, as long as you're within 30 and 100, you're good. If you get a vitamin D.
Yeah.
I forgot what
nanograms per deciliter.
Deciliter, yeah. So, but they're suddenly, if you get beyond 100, they think that you're suddenly going to fall off the cliff and die or have some sort of issue, or health issue. And you're certainly not, right? There's people that walk around with higher vitamin D levels and are doing just fine and probably have much better health.
Yeah.
So
right.
I think staying in those upper ranges of vitamin D in general is a good idea.
And the extra water soluble vitamins, like C and the B complex, you're going to pee out what you don't use, right?
With the exception of B6.
Okay.
So we have seen some people that have gotten too much B6. Too much and too little can lead to some neurotoxicities.
That's pyridoxine, right?
Mm-hmm.
Yeah.
And so there's something different about how that's metabolized, where the extremes at both ends can cause some peripheral nerve issues.
Very interesting. I know when I had to take isoniazid for TB exposure, it's known to deplete B6, and I actually had to take that because of the neuropathy. Very interesting.
Yeah.
Okay.
Yeah.
So in general, to answer the question is, for most people, make sure you get a high quality one. And what I always tell people, you tell me if this is right. One of the things
You're wrong.
Yeah. It's probably as a coin toss, it's probably a good response. Awesome. Thank you, Bill, for dogpiling. That's amazing. I like those two recommendations of Thorne and Pure encapsulations. But what I've told people, if they're going to go look around, a good litmus test for me is to look at what B12 is.
Yeah.
And so if you look at the label, and if B12 says cyanocobalamin, it's probably a crap vitamin.
You're at least not going to potentially get the most out of it, right? So it seems like most of us these days have some sort of inability to methylate well. And I know that you've talked about methylation processes before. And so getting a good methylated B12 and folate and using that as your litmus test for looking at your multivitamin, I think is a good idea in general.
The way I think about it is, if they're going to go through the trouble to really get a good active methylated form, the rest of the vitamins are probably good too.
What's methylated?
So a methyl group, CH3, you don't need to know the chemistry of it, but it's when the body uses some of these B vitamins, they have to have what's called a methylated form because they act as methyl donors. If you guys go back and look through, I talked about methylation and how important it is for some people, especially with mutations that don't methylate well. But most cheap vitamins, the form of B12 is the unmethylated form that actually has a cyanide on it called cyanocobalamin. And your body really can't use that right away at all. It's not even really helpful for what you take vitamins for. So we try to get things in the form we would be getting them in food.
Makes sense.
So it's just a good way to look at it, if it's probably a quality vitamin or not. That's kind of the way when I'm looking online on Amazon with a patient, and they're like, oh, I use this vitamin. I look through it and I pull up the ingredients. If I see that the B vitamins have methylated forms, I'm like, it's probably a quality vitamin. Yeah, that's the only point I was making.
And probably the only other thing I would say about the multivitamins is, if you're a child, I get it. Fight your battles, right? Give the child a gummy if that's how they're going to get their multivitamin. But if you're an adult, try to nut up and just take a capsule, right? Or find a liquid or a powdered form that you could use, because those gummies tend to have a lot of sugars. Let's be grown up.
You're getting a bunch of other crap that you're just not intending.
If you can swallow your food, you can swallow a capsule.
Right.
I had a dodgeball reference. If you can dodge a ball, you can dodge a wrench.
If you can dodge a wrench.
Oh,
you
dodge a
one.
wrench, you
There
can
go.
dodge a ball.
There
That's
you go.
right.
Yeah.
Anyway, sorry.
Okay. Well, how about we get on to the subject at hand, which is the TRT.
All right.
I want to start off also with just a very brief, give me a 1 to 2 minute background on who you are, just so people are new listeners that haven't really heard of you much besides being in the background or something like that, so they can kind of know that you're not just Chris's wife. You have a little bit of education.
Just a little bit.
So about a minute, if you can just kind of go through that, and then I have the first question ready.
Okay, no worries. So hello, everyone that's new. My name is Carrie Hardy. I'm a naturopathic physician here in the state of Washington. I have my own private practice up in northern Washington, up in Stanwood. Even though I'm a naturopathic physician, I use a lot of things out of conventional medicine, a lot of things out of the natural world, try to combine them together into something that will be a better individualized plan for the person that's sitting in front of me. And we are looking at whole health when we're looking at the individual. So things like sleep and nutrition and stress levels and your overall well-being, because it has everything to do with how you walk through this world in good health. So our intakes are typically longer. All of our first patient appointments are an hour long. Follow-ups, if it's an acute, it's 30 minutes. If it's just a regular follow-up, it's 45 minutes. So we take more time with our patients, which means we see fewer patients during the day in general, but we try to make sure that people are feel like they're being seen and feel like they're being heard, which is something that's been sorely missing for a very long time in medicine. I've been in and out of medicine all of my life. As far as when I was 17, I joined the military and worked as a Navy corpsman, which is like a medic or within the range of a nurse, depending upon how you were trained. And I was trained very early on, so learned a lot of different skills. Went on and specialized in the operating room, got out of medical field for a little bit and worked in science for a few years. And then in 2012, went back to school and went to medical school for naturopathic.
Yeah, and she doesn't like talking about herself. She has a bachelor's degree in biochemistry, a master's degree in chemistry, nucleic acid biochemistry specifically. That's how I met Carrie in a research laboratory doing biochem research.
Nerd alert.
Yeah. And another thing I'd like to add is a lot of people have a misconception about a naturopathic physician. Carrie really does practice true integrative medicine, where she does take the naturopathic side, but she brings in the conventional side. Well, she will prescribe medications, full spectrum family practice, women's health, does things like pap smears, regenerative medicine with exosomes, PRP, all kinds of different stuff. So she's kind of multi-talented. Anyway.
And none of this is advice. It's just...
Yeah, we're not giving medical advice here, especially. So that's important.
Well, that was 3 minutes, so let's strike one. And first question is, can long-term use of TRT, long-term use of TRT and testosterone replacement, can that increase heart disease and butt cancer?
So in full disclosure, like Joe Biden, the questions got sent to me early on, right? So when Biden's out doing his interview, the questions come early to people. So I did take a look at those and I chuckled and I'm like, that must have been a Sam question, the butt question. Hi, Sam.
Did
our
you
friend who
look
left.
at Chris's butt and be like, how's that looking?
It looked cancer-free. Yeah.
They probably meant prostate cancer.
That's what I'm guessing. It's prostate cancer.
Which you
However,
go ahead.
so I did take a moment to look into was that cardiovascular health and
Butt cancer.
and
okay.
prostate. Yeah.
So
Specifically, honestly, it said prostate. I put butt.
okay, good. So so we'll get to the colorectal cancer, which is the butt cancer.
Okay.
So long-term use of testosterone therapy. So there was, let me take a step back. And we mentioned this during the first episode we did on testosterone therapy. So back in the day, there was somebody who had prescribed testosterone, and then this other physician saw this patient. This patient ended up with a blood clot and died. All we know is this patient was prescribed testosterone. We don't know anything else about this individual's
This is one
history.
patient?
One patient. And then that got reported, and now there's an FDA black box warning about the cardiovascular risk and thrombotic or blood clotting risk of testosterone.
When was this, by the way?
I want to say like
1950s or something.
No,
like
no.
That? Was it?
I want to say it was like the 70s, maybe.
Oh, okay.
I don't have the timeline down. But anyways, there's a number of studies out. There's a big study that got started in 2018. It's not quite done yet. It's one of the Traverse trials. They have a number of trials. We're looking at a bunch of different things. One of them is testosterone therapy and the safety, long-term use of it, and the safety behind it. There's a number of recent, like over the last 4 years, that show just how safe testosterone therapy is for cardiovascular health in general. I'm going to put on my glasses because I did write down some very specific citations. Exactly. So they have shown that low serum levels of your natural testosterone put you at higher risk for cardiovascular events. They did what's called a non-inferiority study, which means they looked at the therapy, which in this case was testosterone versus a placebo, to see if there was any worsening of cardiovascular events. And they didn't see any inferiority issues, meaning that it wasn't problematic. Hypogonadism, or low normal testosterone, is associated with increased mortality or increased death in men that already have cardiovascular disease. And when they've done testosterone therapy, and this was out of a study printed in the Current Cardiology Report, it's a journal specifically for cardiologists. TRT in hypogonadal men can improve cardiovascular risk factors, reduce the QT interval prolongation, so that's an EKG marker, lead to better outcomes in those patients that already have heart failure, and they actually show a regression of plaques within the arteries or atherosclerosis. And they're talking about physiological levels, and this is where we have to be super careful about what does that mean, physiological levels, because I think that's different for everyone. What current medicine says is normal is somewhere around 260 to 900. Historically, we used to be 900 to 1100, but we don't know. We don't know what normal physiological levels are. And I do know that most guys down in that below 500 tend to feel like shit, just to say it very bluntly.
Real quick, let me just interject real quick. So what I'm hearing from you is not only is it not increase the risk of heart disease, it seems low testosterone naturally, as you age, seems to increase the risk of heart disease.
Yes.
And some studies are showing that by replacing it, you're reducing some of the risk factors
for people that already
have heart disease, and maybe a regression of some already
to include some pretty bad heart disease conditions like heart failure. Okay. Right? These people are having better outcomes by replacing their testosterone to something that's more normal.
Okay.
And normal for them. But I'm guessing within these studies, they tried to keep it in that 260 to 900 range.
And that will kind of segue later on to how you titrate testosterone for your patients.
Exactly.
Okay.
Exactly. And then also the use of TRT to achieve physiological levels does not pose a threat to cardiovascular health, and has demonstrated a cardioprotective effect. This is what they found in that current cardiology report. And that was actually done last year, 2023.
Wow.
And then talking about cancers. So prostate cancer, this is a tricky little situation because we have to think about the level of prostate cancer. One of the most recent conferences that I did where they talked about testosterone replacement and prostate cancer, if the gentleman has prostate cancer that stayed within the capsule, meaning the capsule of the prostate itself, so it's an encapsulated little organ, gland, and it's been treated, and so the PSA levels are now normal. They find it very safe to treat those men with testosterone therapy, and prolonged anti-androgen therapy is causing more harm for these guys than is being helpful for them.
So let me, just for the listeners here with some of the medical terms. So prostate cancer in general is considered an androgen, which testosterone is an androgen, sensitive cancer. In other words, theoretically stimulating with androgens can promote growth, right? Theoretically.
That's the original thought.
That was the original thought.
Yeah.
So that gets to the point. What we're finding is it's not so simple as that. People that are getting on anti-androgen therapy, which tries to block androgens from the receptor, what are you showing again?
That it's actually helpful not only for overall prostate health, but obviously for the man itself, but that the testosterone actually isn't making prostate cancer worse. So when they look at men who...
I need to back up. When I said you mentioned anti-androgen therapy, what were the outcomes on that?
Oh, those men had higher risk of heart disease, death, and just...
So the people that are being...
As Bill would say, feeling poopy in general.
Yeah, so that's what I wanted to clarify.
Yeah.
Okay.
Yeah, so a localized cancer, meaning within the gland itself, that's been treated, they are recommending. There's a lot more of the newer urologists are actually recommending replacing testosterone for these gentlemen. And in gentlemen that didn't have, they didn't know if they had prostate cancer or not, and they were given testosterone therapy, it didn't seem to make their incidence of developing prostate cancer any worse.
That's a key point because that's what people are worried about.
Yeah.
Am I going to get prostate cancer from starting testosterone?
No.
Okay.
No. And then the butt cancer that you actually talked about. So there
even though you were joking.
Even though you were joking. So they have looked at some of the colorectal cancers to see if there was a hormone correlation with that. And in gentlemen that are obese, and sorry if that offends somebody to say that someone's obese, but if you're obese, metabolically not healthy, men in particular, they tend to have low testosterone and a higher incidence of colorectal cancer. So if we give them testosterone, they start to get motivated to lose weight and exercise and do all the right things for themselves. That risk tends to go down. But they haven't shown any direct evidence of cancers, colorectal cancers with reproductive hormones. Now, there's a whole bunch of other hormones in the body, but testosterone isn't necessarily negatively.
You're saying that the low testosterone is correlated with increased risk of colorectal cancers
in men.
But likely because that's corresponding with all the other metabolic issues they're having
that are
and
known
obesity
to be associated with cancers in general.
Yeah, and so by replacing their testosterone, maybe decreasing body fat, increasing lean muscle mass, motivation, mood, sleep, all those improvements, they're more likely to have better outcomes because of their, because let me ask you this, by replacing testosterone, it also has a lot of metabolic benefits, correct?
Oh yeah.
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 Like
Helps.
diabetes protection and things like
Exactly.
that, right?
Exactly.
Okay.
Yeah.
So if someone is on TRT, how often should you actually get your blood work? Let's say we're talking about the person that has, they're not in the testing period where they're trying to find like that good zone. They feel good. They're at 700, feeling great. How often should that person go and get their levels checked, among other things, not just testosterone, but other blood work? And does that change when you're a 40-year-old, a 50-year-old, 60, yada, yada?
So if they're currently on a stable dose, we shouldn't really need to check more than once a year. So one of the providers that I do some study under for hormone replacement therapy says don't test at all, because if they're outside the normal range and a more conventional doctor sees it, they might get their panties in a wad and feel like you're overdosed and you need to cut that back. And then the guy feels like crap because he's like, oh, well, my doctor says I need to cut this back. So the DEA requires that there needs to now be an ass in the seat in front of the doctor to get prescribed testosterone and to continue therapy. That means that these telemedicine clinics are probably going to be shut down because I need a physical person in front of me. And then I request at least once a year testing. I'd like to see twice a year just to make sure that things are good. But once a year is fine. And unless something changes, like suddenly you feel like you're getting a little bit more fluffy around the middle, or you're getting some man boobs, then we got to see what's going on. Are you over converting to estradiol, or is there sex hormone binding globulin up too much? And you don't have enough free testosterone, that we may need to make some adjustments there.
On that, with blood work, what about CBC? Can you talk about that a little bit?
Again, and so if they're in general feeling good, doing a CBC once a year is fine, or at least at a minimum twice a year. I would like to see, for most of my patients, the testosterone and the CBC. I always draw those two together. Now, there's some individuals, and you happen to be one of them, where the testosterone really raises your red blood cell production, and that's a natural thing for testosterone, to increase red blood cell production, which then will increase hemoglobin, hematocrit. The bigger component is monitoring your platelets.
Mm-hmm.
So, and again, more conventional doctors will really get kind of excited if there's high levels of red blood cells and I don't mean platelets, the red blood cells, the hemoglobin, the hematocrit. And they're saying that we're putting you in polycythemia vera, which is bullshit. That is not the definition of that. And so then again, they're trying to cut back on your testosterone when we just need to remove some blood from you.
Use me as an example, because I do have increased red blood cell count. I do have my H&H, hemoglobin, hematocrit with that goes up, but my platelets have never bumped.
Exactly.
They're always normal. And so with clotting risk, we get really worried though when platelets start coming up.
And so then that's a different issue, right? So that's that polycythemia vera,
Right.
and we have to look for causes of that. Rarely is that due to testosterone.
But like my labs say, my platelets are not going up with my RBCs,
Exactly.
so my risk of clotting really isn't.
And there's some guys like yourself, and I have a few other patients, where they just feel better when we keep their hematocrit a little bit lower, their hemoglobin, hematocrit, red blood cells a little bit lower. But I mean, if you go check the blood work of like the Sherpas that are doing the climbing for
At high altitudes.
Or people that just live in high altitude in Colorado, like they're gonna have different lab values than those of us that aren't at that altitude. Does that make them sick?
Like erythropoietin is elevated to increase. Yeah. So again, we got to stop. We got to think about this a little more instead of just being reactive to lab values. You do phlebotomize me. You take some blood out
about once a quarter.
Once a quarter.
Yeah.
I don't know. And I think it's not a bad idea anyway for me.
Yeah. I have a few other patients that are that way. Like about once a quarter, we have them come in. We just draw like
a unit,
150 to 300 mLs off, and they walk out and they feel great.
Okay. So with that, can you get TRT from your normal general doctor?
You can if they're willing to prescribe it. Keep in mind they will not prescribe it unless you are below the reference range of whatever your reference lab is. So for LabCorp, I believe that's like 264 to 900. So you have to, with 2 lab values drawn at least a week apart, have to have values of less than 260, 264, whatever that number is. And then they'll probably prescribe a topical testosterone, meaning like a 3% gel that you would put in your armpits. I've not found that very useful for most of the men that I treat.
Yeah. Well, can you tell me why that's a crappy way to approach a patient? Specifically, like, let's say that I came into you as not your husband, as a patient, like you're a conventional doctor. When I say conventional, I mean that not a functional medicine, not educated in hormone replacement. And they're like, oh no, you're 300, you're above the reference range. And I'm like, but I feel like shit. Why is that a bad approach?
Because you're an individual. We don't know where you were back in your 30s, and we're not necessarily trying to drive your testosterone back to where you were when you were 18, right? But something a bit more healthy. And so not everyone feels good at that 300 level. And it really, for me, it's just that simple. You don't feel good at those levels. And so they're not normal. Even some of the folks within the I believe it's the American Academy of Urology, they're starting to say, well, you should really try to get guys at least to 500. So they're recognizing that those low normal levels may not be healthy for individuals.
I still don't feel well at 500.
No, you don't. And that's why we dose you until you feel better.
I happen to be about 850, 900.
Yeah.
I feel good.
Yeah.
What about you, Bill?
Yeah, I'm typically up about that high. I actually find even when I've tested in the 600 to 700 range, it's not. I don't feel great, honestly.
Yeah.
It's really more than the biggest symptom that sticks around is my sleep quality is still crap when I'm in the 700s.
Yeah.
It's and on the other side, when I've actually been in like the 1200 range, my sleep isn't great either.
Yeah.
It goes the other way. So
for you, that's super physiologic. For you as an individual, that's probably too high.
Yeah. But I know that there's people out there that actually feels pretty good being around there. But for me, it's almost like a feeling of constantly having, like when you very first started drinking like energy drinks, that kind of jittery feel is what I would have almost at all times.
Yeah.
And so trying to sleep with that is brutal, especially let's say the night, if I took my shot in the morning, the night of, I'm not sleeping.
Yeah.
So, to this variation, why certain people feel good at certain levels, there's things like, what's the free testosterone, the sex hormone binding globulin, all these different things. But have we ever looked at how do we measure the effectiveness at the receptor level? Do we know? Just because you have all these other lab values, does that mean you're stimulating it the same? Can you have like testosterone resistance and things like that?
So as you know, what they can do in the research world is very different than what we do here in the medical setting. And it typically takes multiple years, a decade or even more for modern medicine to get caught up with where research is. Currently at this time, there's not receptor level hormone testing for activity for normal healthy states, right? So we look at receptor activity for things like breast cancer, but not for things like, are your cells responding? Do you have adequate receptor activation with testosterone binding or estrogen binding, progesterone
So
binding,
for
et
the
cetera.
listeners, just because you have a blood level of a certain amount doesn't mean it's having the same effect. Like 600 for someone that may feel good at 600, someone else like myself feels terrible, and
Yeah.
that could be a reason.
Right.
Right.
Some cellular receptor resistance.
And so that's why you really treat to symptoms.
Right. And same thing with thyroid, right? And so that's a whole nother ball of wax. But the part of the hormone replacement courses that I've been taking, like they really hammer that cellular resistance and that we don't have good testing for it. And just because a lab value looks normal, the person in front of you isn't feeling well, are you just going to say, okay, see ya?
Well, they do.
I know
It's exactly what they
do all
do.
the time, but that's not good medicine, right?
Mhm.
And there's something causing some cellular resistance. You wouldn't do the same thing to a type 2 diabetic, right?
No, right.
If they suddenly get insulin resistance, you're going to give them insulin and you're going to dose them until their blood sugar's under control. So why aren't we doing the same thing with our other hormones?
Right. And it's always comes down to risk benefit, right?
Mm-hmm.
You know, the benefit is potentially pretty damn good, and the risk for pushing the dose, you know, even to levels within what's considered normal range, it's very minimal. So it's like a disconnect, I think, in the thinking. Most physicians, I don't understand it.
Well, they and you know this better than I do. So a lot of physicians practice only to the standard of care, right? And that's to cover their asses should an adverse event happen and they get sued. Completely understand that. I understand why those standards of care are there. However, we're not all the same individuals. We need individualized medicine, and we need to stop treating people based off of an algorithm and start taking care of the person that's in front of us.
I always hear them parrot, and I'm saying them by my colleagues, evidence-based medicine. I'm like, well, that's fine, but how about evidence-informed medicine?
Well, but they're not even doing that.
Right.
Right? So if we look at all of the research that's behind hormone replacement, and for women, it's even more atrocious, but just for men, right? There's a preponderance of evidence saying how safe it is. But because we had the one report and now there's an FDA black box warning on it, like suddenly it's like we're trying to practice voodoo medicine.
This is this is the same thing with the estrogen replacement and the Women's Health Initiative, isn't it?
It's much
Except
worse
for
than
it's worse than that because it's only one patient.
Yeah.
And we're using this one case study to basically affect the lives of I don't know how many men, right?
Mhm.
Because these doctors are, you know, it's like, and most of them, you know, in corporate medicine, they're not going to go off and try to learn the stuff. It doesn't seem like they are, like you're doing. And so I don't understand that, you know.
There's more and more coming around, but they are out of corporate medicine,
Yeah.
right? They're doing more individualized medicine, which unfortunately for a lot of patients is now a cash only business, right? And patients, and I get it. You want to use your insurance, you're paying good money for it, but that good money that you're paying for that insurance probably isn't going to help you a whole lot to help you feel better.
No, it's like, well, here, I'm going to give you insurance, but all you can eat is Taco Bell. I'm like, but I don't like Taco Bell.
Exactly.
I want, you know, something more authentic. I want a Marco's Taqueria. You know what I mean? You gotta, unfortunately, now we're at the point where, you know, we're having to pay for it. And when you have insurance carriers also owning the care delivery system, which we
easy.
could go, I know,
Take it
get
easy,
off on a
man.
rant. But
next question, Bill.
Yeah, I know. Before I go
Fauci's
crazy.
listening.
Yeah, but it's a real problem. And
well,
anyway.
I will kind of nudge you guys a little bit with some of the testing stuff and someone getting started. We did have this question recently. I just want to touch on it briefly. 300-point swing in test scores. We had someone that they had 3 tests all 2 weeks apart.
Yeah.
And he had a 300-point swing, which really made it so his doctor said, ultimately, yeah, you're fine.
Well, and I know Chris has talked about this before. So there's a bunch of variations that come into what can alter testosterone levels, right? So bad sleep, increased stress levels. What we don't know about that person that had a 300-point swing is the other components within that. Was that total testosterone? Was that free testosterone? What was his sex hormone binding look like? Is he over converting to dihydrotestosterone or estradiol? Like, there's a whole bunch of factors that go into that. So, and then there's a bunch of lifestyle things that will come in and can negatively impact that. We just have to be careful about how we approach that.
And when you say lifestyle stuff, you get drinking, marijuana, yada, yada, yada.
Drinking is the biggest one,
Okay.
right? So, and anything else that's going to impact that growth hormone that we all start to lose as we get older, that also will impact testosterone production. And so I got it. That's complex, but there needs to be more information before we can say why that happened.
Well, regardless, you would treat that patient.
I would most likely, if the patient is not feeling well, even though they're normal, like, we got to do something to help them.
Right.
Yeah.
Right. How about, is there any difference between the actual TRT product? So if you go to one of these designer places where they'll charge you $200 per injection every 2 weeks or a month or whatever it is. We've all had friends that have told us about that. Or an online only company, or a compound pharmacy, or just your normal doctor, wherever they would get it from. I assume some of those kind of general practitioners are not going to use, they're not even going to look into some of the compound pharmacies if they have good practices.
Absolutely not.
So is there a difference even between all of these?
So
the product itself?
Right. So the product itself. So if you're going to your general primary care provider, they're most likely going to prescribe that gel, which again is like a 3% gel.
Like an androgel or
yeah.
Axiom
And so
or something.
normally when I prescribe a gel, it's like a 20% gel.
Mm.
So, and that's from the compounding pharmacy.
I see.
And that's the only place you can get that. Now, the injectable forms, which we're talking about, and I'm guessing that's what that question really was about, the injectable forms, it's often testosterone cypionate for the most part. Typically, whether you get it from your primary care, if that one's willing to prescribe an injectable form, the boutique clinic that's charging you hundreds of dollars, or the compounding pharmacy, it's all testosterone cypionate. Typically, the compounding pharmacy will put it in a different carrier oil so that you're not getting so much injection inflammation. So when you guys first started out with testosterone therapy, like that injection site got pretty sore a couple of days after the injection, and that continued on, right? So
I've noticed that is like essentially gone now.
Right, and that's because you're now used to the carrier oil. And so the compounding pharmacies typically put it in more of a grapeseed oil, where I think the commercial form is like a cottonseed oil. So it's just a difference of carrier oils, but it's still the same product. Now, some of the compounding pharmacies will do other forms of testosterone, not just testosterone cypionate. They'll do like testosterone ethanoate, or testosterone cypionate, or you can get combinations thereof of those. But for the most part, it's testosterone cypionate.
Okay. Question came in. 49-year-old says he has good nutrition. Says he has all the symptoms that we've talked about, especially the big ones, whether that's sleep, recovery, you work out, you eat right, but you can't lose any weight, gain any muscle, libido, yada, yada. His doctor said his levels are quote unquote normal. Unfortunately, I don't know what that means. But I'm sure we can kind of guess. Anything above 256, it sounds like, roughly.
Yeah.
He does live in Canada, so I have to address that. But is he just out of luck? What's a recommendation for someone like this?
So there's some really great websites that you can go to. One of the first ones that I would look at, and I do know they have a strong naturopathic community up in Canada. So if you find a naturopathic physician that will prescribe hormones, great. Otherwise, I'd look at the Institute for Functional Medicine, IFM. I believe it's .org. It's either .org or .com. Find a good functional medicine provider. That group has trained people throughout the world. And so I'm pretty sure they'd be able to find someone. But just because his testosterone numbers are normal, again, we don't know the subset of those. Like, is that just total testosterone? What about his free testosterone? What's sex hormone binding look like? What about dihydrotestosterone? What about estradiol levels? Like, all of those things are important for us to assess. But in general, if he's got symptoms that are associated with hypogonadism or low testosterone, he probably should be treated and at least given a trial dose to see if it makes a difference for him.
Yeah, that makes sense. Is it true that once you pop, you can't stop? As in, once you start TRT, are you pretty much, and you're starting to feel good, everything seems fine, can you not get off it? Can you wean yourself off it even? Or are you stuck doing it forever?
So unless there's something like a tumor up in the pituitary, which is like the little testicles hanging down from your brain.
Easy with the little part.
Well, they are tiny. The pituitary is a small gland. But anyways, that's where a lot of the hormonal signaling comes from for like the ovaries and the testes to produce hormones. So unless there's a tumor up there that hasn't been resected or in light of any particular trauma to the pituitary, that
like
can
concussion
be,
or something like that.
can be repaired. If you're starting on testosterone therapy because something along the way has failed, you're probably on testosterone therapy for as long as you want to be on it. You can come off of it. Your body will eventually go back to making its own levels back to baseline where you were before over time.
But it's not going to be like, oh,
it's not you're not jump starting the system.
Okay.
No, and it's like, why when you, and this is my perspective, and Carrie, correct me if I think I'm wrong on this.
Oh, you're wrong.
Right.
Mm-hmm.
So I started when I was 45 because of very low testosterone. It's not going to come back.
No.
You know, that's, you know, women when they go through menopause, it's not coming back.
Yeah.
So I don't really understand the thought process. It's like, well, I'm replacing something that I've lost. So, because I felt like shit. And so why would I want to stop that?
Well, I think it could be something where someone is like, if you are out of shape and fat and all that kind of stuff, you start to get into shape, it kickstarts everything. Everything can start to work better. And I think maybe some people are just wondering, does that work similarly where, okay, I've put healthy vitamins in, I eat great now, I've changed my lifestyle completely, but I had low testosterone. So actually thinking about that, maybe there is an instance, depending how low you were, that if you went from being an obese person that was around the 400 range, if you lost all that weight, you've changed your life, your sleep is better, your nutrition is better, you've gained muscle, is there a chance that naturally you could be producing more at that point?
He most likely will be producing a little bit more at some point, but will it be enough to help him feel good again?
That he was feeling on the replacement.
Exactly. Yeah. I don't know. The short answer to that is I don't know, right? And to the whole, like, why would you stop that? Well, you know, unfortunately, we kind of are in a society now where people are very much like, well, I'm getting older, right? Which that fucking drives me batshit crazy. Sorry for the language, but there's no other way to say that. Like, you know, well, I'm supposed to, you're supposed to feel like crap until you die? I don't think so. So if you have the financial means to, and it's been prescribed for you because you're already deficient and maybe you weren't that individual that was overweight and your testosterone was getting all converted to estrogen, and you want to be on hormone therapy to live well longer, not just live longer, right? Like, there's plenty of people in the nursing homes that are living longer, but they're not living well.
Quality of life.
Exactly. Then stay on the therapy. You're not hurting anything.
Matter of fact, you're probably protecting against cardiovascular disease,
A
and
bunch
all,
of things.
osteoporosis,
Dementias.
all these things. So if you think of it that way, you're kind of, because if you look at what are we supposed to do as humans or animals in general, we live long enough. All nature cares about is we live long enough to reproduce. After we're past reproductive age, who cares?
Right.
As far as nature goes.
Right.
But we're individuals that still want to live productive, healthy lives past our reproductive years. So that's my thought process. Going back to the obese person, if they're a young obese person, Carrie kind of touched on it briefly. Excess fat cells will produce increased enzyme called aromatase, which takes your testosterone you are producing and converts it to estrogen. And so without doing testosterone replacement, if you lose your fat mass, you'll decrease your aromatase, and the testosterone you are producing won't get converted as high, right? So, I would argue that if it's like a 20-something that is just really obese, let's go through a hardcore exercise nutrition plan.
Probably put them on one of the GLP-1 receptor agonists to help with weight loss.
Like semaglutide or something like that, right?
Ozempic, the trade name. Yeah.
Right. Which is super effective. That would be more of a short-term intervention as opposed to a short-term testosterone intervention, in my mind.
Yeah. Yeah.
I see. I mean, that makes sense. What about someone that is 75, 72, something in their 70s? Giving them TRT?
Hell yes. I've not seen him. So I've not renewed his prescription in like the last year. I had a 90-year-old still getting his topical testosterone.
Safe, everything.
Yes.
Same as me doing it, like the safety protocol or profile.
Well, and the potential benefits would far outweigh.
Maybe even more than what we're dealing with at our age.
For sure.
It's going to be even greater at someone at that age.
All-cause mortality, the biggest killer, as opposed if you don't have cancer, die of a heart attack, it's frailty. It's loss of muscle mass and bone density. Maintaining your muscle mass into old age is like the biggest thing you can possibly do to be healthy in old age. And testosterone for men especially is huge. In hormone replacement in women, crazy important for maintaining bone density and all that.
So you said something, you briefly mentioned about dementia or Alzheimer's, and there's some benefits there. Can you briefly go into that? Because that really interests me there.
And so this is some newer research that they're kind of looking at in that, and it's mostly been in women, where it's no big surprise that when women go through menopause, some of the things that start, not only do we start to lose like muscle mass and bone density, and skin starts sagging and hair starts falling out in places we don't want it to and growing in other places we don't want it to. But also we start in dementia in our 50s because we're going through menopause, because that loss of estrogen, and same thing for you guys, right? So even though you guys are both fit and you're not over aromatizing to estradiol, so you're not looking fluffy, you're still getting some estrogen that is so healthy for good brain health that it's remarkable. They're showing one of the providers that I have done some training under for hormone therapy has gentlemen that have been on medications to block the estrogen, right? So this is where I'm starting to change some of my treatments, in that I'm really having a big discussion about the aromatase inhibitors that people like to take because I want to keep my testosterone levels higher. Well, then we need to give you more testosterone and not give you another medication to block the estradiol, because that's helpful for brain health. And those individuals that are on some of those aromatase inhibitors, like anastrozole, they're starting to see that they're having some dementias that are showing up. as well as some changes in bone health also, because you guys need some of that estradiol as well for bone health. And when we take that away, replete a little bit of estrogen in those guys, like cognition comes back, they waken back up.
So is this
And-
why you
and-
have Chris on testosterone?
One of the reasons.
Well, no, I can't say it.
Easy.
Yeah.
Take
Well,
it
I want.
easy.
That's
Daddy
for-
needs to work.
So, back to a point she's making about dementia and the neurodegenerative diseases like Alzheimer's, Lewy body, Parkinson's, all these kind of neurodegenerative disorders. A lot of people think they start in old age. They do not. They become clinically apparent in your 70s and 80s.
Mm,
They start in your 50s
wow.
and they're subclinical. So the processes in the brain are starting in middle age. What you're not seeing what's happening by the time you diagnose someone where they're having significant symptoms. It's not very reversible. Now there's some things you could do to improve it so much. If you look at all the drug trials for Alzheimer's, when they have they've had a diagnosis, when they have significant symptoms already, they're not effective. So we need to really start looking at prevention of neurodegenerative disorders. And one of the things we can do is optimize hormones.
Mhm.
Gotcha.
So that's a very important point because people are like, well, Carrie just said in their 50s they're having dementia. No, that's when the process starts. We
Right.
just don't clinically,
How-
it's not relevant. yet.
How old are you, Chris?
54.
Okay.
Right. No, that's my point. That's what. But Carrie and I are very much focused on prevention, especially it's hit home to us in our mid to late 50s.
Let's say 50s is when that process is starting.
Yep.
But you're saying you might the signs might be so minuscule that you're not even seeing anything.
Right, because we just I'm getting older. I got a little bit of brain
Yeah.
fog.
Oh, my
or-
short-term memory is a little crappy or something.
Yeah, and our it's like anything else. Our
Yeah.
brain, it's like our brains are remarkably adaptive.
Okay.
Right. You see stroke patients that will have damage to the brain. That's the other parts will kind of come in and
Right.
But there's a point where that is not going to happen anymore, and that's why we kind of see the processes start around our mine and Carrie's age, but we're not clinically apparent until 70s and 80s.
Right.
Yeah.
So
now, Chris's drooling is just natural.
that's just a thing.
That's just a
Yeah,
thing.
yeah.
That's
not
what
his
drew you
dementia.
in when
Yeah,
at that lab that you guys were
exactly.
messing with your beakers at.
Exactly.
Got it. So we only have about 10 more minutes, and so I have one more question. Okay, and one's a little bit more personalized that someone emailed in, and so I'm going to read that question here. It says, "I'm 46 and recently got a full blood panel from my PC, primary care, I think.
Mhm.
Mhm.
I was an athlete in high school and have mostly always kept myself in good physical shape in my 30s. I was swimming and lifting weights and yoga. I started BJJ at 39 years old and have a brown belt currently. In the last year, definitely noticed my recovery decline and energy levels drop. Father Time is undefeated. At the time, I was training 4 to 5 times a week, BJJ, swimming, cycling, and doing kettlebell circuits on non-BJJ days. So very active. Doing some kind of workouts every day. In the last year, I scaled way back on other workouts except for the BJJ addiction. I still train 4 to 5 times a week, but that now includes some teaching and private lessons so that I can modulate training intensity better. Having some knee issues that I've currently in PT, that he's in PT for, no ligament or muscle tears or loading strength. So he says, so my numbers are 849 for total testosterone. Free testosterone is 57.9. Bioavailable testosterone is 106.5. SHBG is 77. And albumin
Mhm.
is 4.0. I was surprised that my total T was so high, but definite issues with bioavailable being super low and SHBG being high.
Yep.
I'm wondering what the doctor's interpretation of these numbers would be. Any guidance is appreciated. I have cycled Phagogia agrestis.
Mhm.
Did I nail that?
You're close. Yeah.
Thank you. Tanka Ali
Mhm.
in the past. I've cycled off for several weeks before getting my blood work done. My goal is to do all the physical activities that I love and enjoy for as long as possible.
So whenever we have higher levels of sex hormone binding globulin, and for those listeners who were wondering, like, why was the albumin included in there? That's a generalized protein carrier. It'll bind up hormones also, so we need to take a look at that as well. And that's typically included on most just regular blood panels. But what we don't know about his estradiol levels. So his free testosterone is being bound up too much by that very specific sex hormone binding globulin. And so sometimes we need to do something to encourage that. And believe it or not, for guys, to increase testosterone, we may want to put a little estradiol in for him just to replace testosterone in that sex hormone binding globulin spot and allow him to have more.
Oh, so it's like a competition thing, right? So you're giving an estradiol to take up a space in the sex hormone binding globulin.
Yep.
I will say, just hearing his history, he, and it sounds like he's made some adjustments, but the allostatic load stress cup thing.
That's what I was thinking.
Yeah.
Dude, that was a very ambitious activity plan. And then you start BJJ. If he was doing all that without Brazilian Jiu-Jitsu, that's fine. You add that, I was in the same problem. Once I added in Jiu-Jitsu, I had to scale way back to the point I'm now at 3 days a week training at 54 years old. And if I train more than that, I will overtrain. It's just, and then off days, it's just stretching. And
you do all the recovery stuff that
I do everything I can possibly think of for recovery.
This is a perfect example, though, of the levels thing that we were talking about earlier. How 849.
Yeah. But that's total. That's
right.
Everything the body's making.
And that's the number that everyone looks to.
Right. And that's not enough.
But
right?
what's getting to his cells, right?
And so then the other thing, and this would be where it may be a little interesting, especially for you, Chris, to see if we could push the pace a little bit. So one of my conferences last month, we talked about mitochondrial health, right? So the little powerhouses, if we will, of the cell where energy currency is made. And so Chris is my guinea pig for a lot of things. Often if I can do it, I do it as well. But supplementing with some methylene blue to help his mitochondria function better might also help support those energy levels for him also.
Wait, with this fellow that we're talking about here?
Yeah.
Okay. Yeah, let me tell you something. What's his name?
Oh, we don't have one.
Okay. So
it's Joe.
When I started on methylene blue, so we get mitochondrial dysfunction as we age anyway. So this thing kind of rescues the electron transport chain, which is part of the mitochondrial machinery. I went from, and you can attest to this, Bill, I went from maybe getting 2 rolls at a time, having to take a couple rounds of a break, to rolling like 5 or 6 rounds in a row.
And that's over the last month.
Over the last month, just from, I know it sounds like a sales pitch, but just from starting methylene.
Well, you were done on Saturday. And typically when you're done, you're done. And you did another one as the last round. Everyone was done.
I did 8 rounds.
You did demolish the blue belt.
That's true.
Wasn't going to bring it up.
I did 8 rounds on Saturday. And so that methylene blue kind of rescued, I think, is the mitochondria. You should look into that. Carrie got it compounded for me.
Is this a prescription?
Yeah.
Only? Okay.
Well, there's pharmaceutical grade that's available online, but it is dosed on body weight, and so they really should see a provider that understands how to do that.
Yeah.
To get the right dose for that individual.
The dosed correctly, the risks are minimal. The only thing you'll notice is your pee looks aquamarine. I have like blue-green pee.
And it will interact with some medications, so you do have to be careful, which is why
you can't be on
just do supplements,
especially on
it looks cool.
Methylene blue, especially if you're on any psychiatric medications like SSRIs.
Yeah.
It has very potent monoamine oxidase inhibition. We don't need to get into that, but it will definitely interact with certain medications, so you got to be careful.
That's why the thing that you said, our friend that had the blue tongue, that potentially that could be like a weird thing.
No, that's only if you take the
Oral
oral, the
one.
troches. I
Oh.
take capsules and swallow them.
Okay.
I don't have a blue tongue. Yeah, if you have the little troches that you just stick in your mouth.
Got it.
It'll turn your tongue blue.
Yeah,
But it'll go away.
yeah, yeah.
It
Sure.
only lasts
But
for a few hours.
that's something to look into.
But
I
it
think
has to be dosed appropriately.
yeah, but
so that's the
if
big
he
thing.
can look into that for finding a good functional medicine doctor willing to prescribe it, there's a certain milligrams per kilogram dosing that would be for me that I hate to use that cliche term game changer, but it really has been for
Mhm.
me over the past month.
Well, yeah, I mean, I definitely noticed it because once again, you're not, because people might hear and be like, he's doing 6 rounds and he's like proud of that. We do 15 to 20 minutes of situational sparring
Before
our open mat.
Yeah.
So you're talking 15 minutes straight of situational and then getting six. We do 6-minute rounds typically. So
Yeah.
it's and he's an old ass dude. So
yeah, but it's been a huge change. So
yeah,
yeah.
100% because you used to literally it had to be a round break.
Yep.
It had to, and then you weren't doing 6.
No.
Also,
Yeah, I'm going back to back hard rolls too. So which
Yeah,
I'm very excited.
Hard
for.
is
Well, the last one, I you're right. That was a little, but
That was a mauling. That poor kid.
I shouldn't have mauled our.
revenant.
Yeah.
Anything else? That's the questions I have. We ran up on our time limit here. We got 3 more minutes. Anything else you want to say?
No, I just want to say.
I was talking to her.
Oh
No, go ahead. I'm joking.
no, that's okay. I just want to say how much we're gonna miss Bill and Olivia. Makes me a little emotional talking about it. But we're going to continue the podcast. It'll be a little spotty maybe this month, but we're going to be back going strong.
Mhm.
It's just a, kind of a big loss to the academy. So
Yeah.
Yeah.
Yep.
So anyway.
I definitely agree. We are going to miss you guys very much. We love you guys and wish you the best in your new position, in your new transition to Arizona. And so
I didn't know what she was going to say. Well, I don't know, Bill. Maybe Bill was sharing something that I didn't know.
And for those of you that are really serious about health, like you got to be all in, right? And medications aren't just going to change everything. You got to put the work in too, right? So it's not easy. But these things like hormone replacement therapy I think are essential for living well longer in life and continuing to be, I plan on doing jujitsu until, the crypt keeper comes and takes me, just a couple more years. But, I don't have any thoughts about slowing down. I don't have any thoughts about retiring, except for because I want to, not because, I'm too old to do this shit anymore.
Yeah.
So that's a cop out and people need to stop it.
Right. No, I think that's well said. And, just to tease the next episode, I want Carrie here to see it, is we're going to talk a little bit about Zen.
There we go.
We want to talk about this popular thing that people have fallen out of their mouth when they roll. And it's getting a little weird.
All right, folks.
All right.
Thanks, y'all.
Later.
All right. Yeah, you have some